Hello and welcome to the second part of our 2020 opioid series, Building and Leveraging Partnerships with Providers, offered by the National Association of State Head Injury Administrators. I am Gabriela Lawrence Soto, NASHA's Training and Education Committee Chair, and Maria Crowley, NASHA's Director of Professional Development, is our webinar organizer today. Thank you for joining us. NASHA is a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. A GoToWebinar user guide is available for download from the NASHA website. This is a great resource for making the most out of your live webinar experiences. Handouts of today's presentations are available for download, so check your attendee control panel for the handouts pane. To ask questions during the webinar, please submit it into the questions pane on your control panel, and our organizer, Maria, will forward your questions to our speakers at the end of the presentation. If we run out of time, the presenters will respond to your questions via email. As always, continue education credits for social workers and certified rehabilitation counseling, as well as general certificates of attendance, are available for today's event. At the end of the webinar, you will receive an evaluation and instructions on how to obtain credits via email. The webinar will also be archived for later access on our website. I would like to introduce today our presenters. We have Brad Hartman, and he is a public health program administrator with the Bureau of Family Health at the Pennsylvania Department of Health. Brad spent 5 years with the Department of Labor and Industry before starting his career in public health. Brad has experience in grant writing and serves as project coordinator for multiple grants. Brad holds a BA in social work from West Chester University. We also have Steve Wade. Steve holds 35 years of experience in management of voluntary nonprofit membership organizations. He has been the executive director of the Brain Injury Association of New Hampshire since 1992 and acting director of the Brain Injury Association of Maine since 2014. Steve also serves on the Brain Injury Association of America Board of Directors. Steve holds a MBA and has been heavily involved across New England in establishing community partnerships, obtaining funding, supporting advocacy, and awareness on behalf of brain injury. I am Gabriela, the project manager with the Massachusetts Rehabilitation Commission, and I'm coordinating TBI grant state activities and co-leading opioids and mental health concerns national work group, serving in mentoring of other states in this area. I have worked with at-risk, low-income, youth, disabilities, and older adults. I hold many years of experience as a case manager, doing staff development, training, and partnership building across service systems. I am currently pursuing a master's in program and project management at Brandeis University. I would love to turn it over now and welcome both of our other presenters, and Steve, take it over.
Great. Well, thank you, Gabriela, and welcome everyone. I'm so glad that you're able to join us today. This is certainly a leading edge topic and a good one. Building partnerships has been a theme certainly within the brain injury movement for a long, long time. And this is, again, a great example of where strong partnerships can really make excellent progress. So as Gabriela mentioned, I'm currently executive director in New Hampshire, the BIA, and also consulting executive director in Maine. So I'm going to talk about both states. Both New Hampshire and Maine, have been sort of the front line of the opioid overdose epidemic. Very, very high incidence in both states. I think Maine might be number 3 nationally, and maybe New Hampshire is 4th or 5th. So I'm going to just go back about 3 years and first talk about the New Hampshire experience, and then a little bit about what Maine is doing as well. So in New Hampshire, within the Brain Injury Association, and also within the lead agency for brain injury in New Hampshire, the Office of Developmental Services, we started to notice more and more people ending up in rehabilitation as a result of anoxic or hypoxic brain injury, and in most cases from overdose. We also, one of the skilled nursing facilities in the state, Crotchet Mountain Rehab, had a really major increase in number of people in long-term coma as a result of overdose. So we started to wonder what was going on, and I think what was happening, which a lot of people weren't aware of, is that people were overdosing and surviving their overdose, but oftentimes with anoxic or hypoxic brain injury. And it was just totally unrecognized by all of us working in the field. And the state and federal partners really were just sort of learning this as well. So we reached out in partnership with, again, the lead agency for brain injury in New Hampshire. We reached out as the Brain Injury Association to the Commissioner of Health and Human Services and talked about what we were seeing as we thought really as a crisis in terms of people, again, a lot of people surviving overdose, but oftentimes with some level of cognitive impairment all the way from mild to severe. So the commissioner was able to get some initial funding for the lead agency, the Bureau of Developmental Services, to working with BIA, the Brain Injury Association of New Hampshire, to put together essentially a task force of all the stakeholders in this area. And the first 6 months was really just putting together the task force, which was relatively easy. People were very interested in this, very interested in trying to make some progress in this area. So the task force has been meeting for the last couple of years and did a lot of work, again, talking with different agencies, organizations, working in the field. Oftentimes, as I think many of you know, there's silos within the state. Behavioral health and substance use is in one silo, brain injury services, vocational services, or developmental services are in another silo, and oftentimes there's not a lot of good connection between, again, the behavioral substance use system and then the brain injury system of care. So, as well as community providers and partners, there's been very little overlap, and particularly in New Hampshire. Maine has had a little bit more success in this area. So anyway, this group of stakeholders has been meeting, doing a lot of research, and has come up with a report with recommendations for the Commissioner of Health and Human Services as well as for the Governor. A key focus that has been identified is trying to raise awareness, particularly raise awareness within the opioid response community and the substance use disorder community about brain injury and the fact that brain injury is potentially an issue, and that one of the reasons oftentimes, I think Dr. Corrigan has talked about this as well, that people are not successful in treatment is because, again, of undiagnosed or unidentified brain injury or some level of cognitive impairment. So essentially, the plan and recommendation talked about trying to educate first responders, educate emergency departments around this as a potential issue, raising awareness. And then also creating some type of service linkages between those organizations and the brain injury community, particularly the Brain Injury Association, in terms of trying to provide a neuro-resource facilitation or resource facilitation in terms of helping to guide and provide support for families and caregivers in navigating, which can be a really complicated system of care. In terms of tangible things accomplished so far beyond the report, one of the things accomplished was to put together we call a RAC card, or a basic information card, about the link between anoxic hypoxic brain injury and opioid or substance use overdose. And that's being distributed again in the kits that are given out to people who overdose, as well as, or basic information packages, as well as information provided to the emergency department and first responders. So we've made some good progress again in distributing those RAC cards, but it's only really a first step in terms of raising awareness. And there's a lot more that has to be done. So, but again, I think the thing I'm most excited about is that for the first time, we're actually crossing those silos of behavioral health, substance use, and brain injury and community services. So it's the first time any of us have really been talking to each other in a long time and about an issue that's really reached crisis stage. So I think Maria and the team at NASHA have a copy of our work plan that we've developed for New Hampshire as a handout. And hopefully that will go into a little bit more detail in terms of some of the things we're hoping to do. So in terms of Maine, our focus was a little bit different. The lead agency in Maine, the Office of Behavioral and Developmental Services, both lead agencies, or both agencies there, talked about trying to reach out and try to, again, connect to people working in the field. Maine, as I mentioned, was really in crisis stage. A lot of overdoses. Really, I think next to West Virginia, perhaps the most of any other state per capita. The lead agency for brain injury in Maine applied and received an ACL grant. I know last year, I think 3 new ACL grants were given. They were shorter. They were 2-year grants. And a big focus of that grant is on the opioid crisis in Maine, and also on substance use in general, but again, focusing more on opioid. So in Maine, Governor Mills put together an opioid response program. I think it was her first executive order when she took office a year or so ago. That team, that response program, has really taken the lead in terms of addressing this issue. But again, having very little awareness of the connection between anoxic hypoxic brain injury and overdose. So one of our first goals was to make a connection with the governor's opioid response program. And within that program, there is a clinical advisory committee. So we succeeded in getting a brain injury representation on the governor's opioid response clinical advisory committee. Dr. Tony Pedraza, who's a neuropsychologist, well known, respected in the state. So again, that was sort of step one. Step two was really to try and, again, raise awareness about this issue within the opioid response program, both in terms of the annual report that the opioid response program is submitting, as well as there's also an opioid response summit meeting each year. We were hoping to have space at the opioid response summit, have several sessions that we can talk about this issue, but because of COVID and the changes of the summit going from sort of a in-person summit to a virtual, they had to cut way back on the number of presentations they have. So we were not able to include presentations in the current opioid response summit, but we instead are going to be doing webinars over the course of the year for the stakeholders in that area. So that's wasn't what we had hoped originally, but it's still working towards what we're hoping to accomplish ultimately, I guess. So I just wanted to take a few minutes too, relative to Maine, to go through some of the specific things we had identified as deliverables within the ACL grant, which we've been working towards and working on currently. One was to try to build and strengthen connections, again, between the brain injury community and the substance use disorder system of care. And a key part of that was to do several webinars, which we did. We had reached out to there's a coalition that looks at education within the behavioral health and substance use disorder community in Maine. And they're well positioned. They have several thousand people working in the field on their database. So in partnership with that group, we were able to host a webinar on, again, opioid overdose and brain injury. In addition, we had a whole track devoted in the annual brain injury conference in Maine to the issue of substance use and opioid overdose and brain injury. That was, again, very successful. The people working in the field and the educational collaborative organization was able to get the word out to, again, many thousands of people working in the field. So that was very helpful. So let's see, what am I forgetting here? So we're also going to try to provide cross-training to the brain injury community as well, in terms of what happens when you have folks that you're working with that have co-occurring substance use disorder. So that cross-training piece is important, and we've really been fortunate to work with Gabby and the team in Massachusetts, since they're a mentor state under the ACL grant. They've developed some really nice training materials and modules that we've been able to adapt as a partner state in Maine. So that's, again, we're pretty close physically anyway, but it's been great to have that connection with Gabby and her team. So again, I'm just looking at some of the other things we're hoping to do in Maine. The whole opioid response program is looking at trying to strengthen opioid overdose surveillance in the state. And of course, there's been no effort to include overdose and the resulting brain injury in that surveillance effort. So that has been one of the goals of the ACL grant in Maine, is to really collaborate and partner with the opioid overdose response surveillance program and see how we can include information in that about opioid overdose and resulting brain injury, or some levels of brain injury. I'll say it's a tough, we're finding as we're getting into it, it's a really tough thing to do, but unless we're at least trying to make the effort, it's not going to happen. And I know there's been a lot of, in terms of transferring from the ICD-9 codes to the ICD-10 codes, it's been a little bit more complicated in terms of brain injury and the many types of brain injury. And we've struggled a little bit in terms of identifying the clear codes for anoxic and hypoxic brain injury as a result of substance use or overdose. It doesn't seem like there's clear connections there. And I think the ACL data work group has talked about that on a number of occasions. So, and then finally, the other piece of the focus in Maine has been really reaching out to the substance use disorder agencies at the community level and trying to provide support to those agencies. And the Brain Injury Association in Maine is fortunate to have 2 full-time neuro resource facilitation positions, and those positions are funded through a state contract with the lead agency in Maine for brain injury. And so the neuro resource facilitators have been reaching out over the last few months to substance use disorder agencies. And it's kind of interesting what we found in terms of needs. It seems like the #1 need has been on staff training. Those agencies at the community level are just desperate for training around brain injury and how you work with folks with living with brain injury, particularly who have co-occurring, again, substance use disorder and brain injury as well. So, so there's a real need there. I know the Brain Injury Association of America has a brain injury fundamentals, sort of a pre-programmed, pre-developed training, and we're currently going to be targeting with 3 substance use disorder agencies to do brain injury fundamentals training for their staff. So the second area of need we've been finding is tremendous need for informational materials, not just for professionals, but also for the families and caregivers that those agencies are working with. So, and the third thing we're trying to do is to really try to create a service linkage, I guess, or referral pathways where we can essentially partner regularly with these agencies, and as they're working with folks that they identify, they can then link back to both the Brain Injury Association in Maine as well as the state lead agency. And it's interesting in talking with the substance use disorder agencies, many of them say they have what they call community partners or community partner organizations. And what they're suggesting is that the Brain Injury Association become a community partner, and that way have, again, a regular routine, whether it's biweekly or monthly meetings with their team, their case managers, their social workers, and really, again, trying to open the door, create a linkage, again, between these substance use disorder agencies and the Brain Injury Association, and ultimately the services that are provided by the lead agency for brain injury in Maine. So, so that's where we are at right now. I will say this is all very much a work in progress. We're making some good progress towards, our ultimate deliverables and objectives, but it's a lot of work, but it's very rewarding as well. Again, opening up linkages and pathways that we've never had before, and again, trying to break down the silos through these partnerships between different state agencies and different provider network. So with that, I will close, and I guess we're going to be leaving it open at the end for some questions and answers, hopefully. So thank you very much.
Thank you, Steve. Now we're going to turn it over to Brad.
Hi, yes, I'm Brad Hartman, and I work for the Pennsylvania Department of Health, the Bureau of Family Health, and we've been partnering with the Brain Injury Association of Pennsylvania. I'm going to first talk about how our program is funded through the block grant funding, the Maternal and Child Health Services Title V block grant program. It acts as a safety net provider for healthcare services and essential public health services for women, mothers, infant, children up to age 22, and children with special healthcare needs and their families. The program was created as part of the 1935 Social Security Act as a commitment to improving the health and well-being of the country's mothers, children, and families. The Health Resources and Service Administration, also known as HRSA, is a federal agency that oversees the Title V Block Grant Program at the federal level, and it is managed in Pennsylvania by our bureau, the Bureau of Family Health. Every 5 years, our bureau is required by the Title V Maternal and Child Health Services Block Grant to conduct a 5-year needs and capacity assessment, a state-level comprehensive assessment of the health status of the maternal and child health population in Pennsylvania, including women and mothers, infant, children, adolescents, and children with special health care needs. The objective of the assessment is to identify the priority health needs that will guide state and local Title V work over the next 5-year funding cycle. During the assessment, the Bureau of Family Health evaluates its capacity to serve and meet the needs of Pennsylvania's maternal and child health populations. The Bureau has developed brain injury and opioid training for substance use and rehabilitation programs to help meet the needs of children and youth with a brain injury or who may be prone to a brain injury due to opioid use. The Bureau has contracted with, as I said, the Brain Injury Association of Pennsylvania to develop and implement a curriculum. The intent of the training is to make professionals in the brain injury and substance use fields aware of the correlation between brain injury and substance use, as well as provide resource information that may be used for the clientele they serve. Now, the Brain Injury Opioid Training Program, it works for people who abuse opioids because they're more likely to sustain a brain injury as a result of their opioid use due to decreased respiration and prolonged periods of anoxia. The training course is designed to assist substance abuse treatment providers to better understand the interaction between opioid misuse and brain injury, how associated cognitive impairment impact response to treatment, how to most effectively work with people with brain injury and adapt treatment for maximum success. It is an 8-hour course divided into 4 classes. It is the brain basics and the toxic brain, understanding the effective pathology, cognitive, emotional, and behavioral techniques for treating persons with co-occurring opioid misuse and brain injury. And the 4th is the integration of client needs, resources, and funding. I like to get into a little more detail than that so you have a better idea of what these classes actually will do and what participants will come back with at the end of their training. For the first one, the brain basics and the toxic brain, it includes brain anatomy and function, the biological basis of behavior, mechanisms of injury, and the impact of opioids on neurochemistry and brain structure. The learning objectives include describing the types and epidemiology of brain injury, able to list at least 4 common physical, cognitive, and behavioral problems associated with brain injury, describe the impact of opioids on neurochemistry and brain structure, and describe why chronic hypoxia from misuse of opioids and revival with Narcan creates cognitive impairments that can impair subsequent substance abuse treatment. The second, understanding the effects of pathology, topics will include screening tools for clinicians, neurocognitive assessments, and how to use this information to develop customized interventions for managing challenging emotional and cognitive issues. Additionally, developing environmental supports and cues and methods for implementing productive daily activity patterns will be addressed. The participants will be able to describe screening tools to identify traumatic and non-traumatic brain injury, be able to define neurocognitive assessments, and list 4 tests that measure abilities important in treatment, and be able to develop customized interventions for working in substance abuse with individuals who may have brain injury. The third class, those topics will focus on substance misuse and how to pair cognitive interventions with substance misuse interventions in order to increase treatment success. And then participants will be able to describe how memory and executive functioning impairments impact substance misuse treatment, identify strategies to minimize the impact of cognitive deficits on treatment, including external memory devices, to define and state the training stages in memory notebook procedures, and describe structuring individuals and group sessions for success, including using metacognitive strategies and perspective remembering strategies. The final one, the integration of client needs, resources, and funding. This part of the course will focus on co-occurring brain and substance misuse resources, including community-based treatment options and supports. They'll be able to describe the unique needs of individuals with brain injury as they impact treatment, identify brain injury specific treatments to consider, identify funding sources for brain injury specific treatment, and to identify other sources of support for individuals with brain injury. This course was developed by neuropsychologists and neurobehavioral specialists from the Brain Injury Association of Pennsylvania in collaboration with the Pennsylvania Department of Health. It's a flexible course and can be delivered virtually over 2 days or 4 days, depending on the needs of the providers. It's also a great example of building and leveraging partnerships. In this particular curriculum, they use video slides from the Roads to Recovery video clips from the Brain Injury Association of New Hampshire in the actual brain injury and opioid training. And I want to thank you to Steve Wade for helping us provide that. You can provide PA Certification Board and National Association of Social Work CEUs. Those are available, as well as certificates of completion awarded at the conclusion of all events. Now, from the research I've done, I haven't seen many other trainings like this throughout the country. I tried to do a lot of research on that, and it seemed to be very difficult to find. And I believe once this particular training is implemented, that it's something that could be used nationwide. And I believe the contacts through NASHA would be helpful to make that happen. Now, at this point, we are still in an implementation stage, mainly because of the coronavirus, the COVID-19. The Brain Injury Association of Pennsylvania was completely ready to go forward and implement the training. They had training scheduled, live training scheduled and ready to go, and it all had to be canceled. And we've been kind of on hold since then. And what they have been able to do is take what they've made for live training and put them into possible virtual environments, which is what we've been working on since this all started. The good news is the Brain Injury Association of Pennsylvania and the Department of Health were able to contact the Pennsylvania Department of Drug and Alcohol Programs, also known as DDAP, which fortunately for both sides, DDAP was actually very interested in a brain injury and opioid training. And they told us that it was a need that they had. They have a lot of training on their training management system, and that was one area that they did not have. And again, that goes back to looking at how there's just not a lot of training out there for this particular topic. So we're working with DDAP, the Department of Drug and Alcohol Programs. We were introduced to the training director at that department, and we've been in regular contact with them ever since, trying to get things started. Now, it is still in an implementation phase. No trainings have been scheduled yet, but we are very close to that right now. And let's see, one second. Oh, the great thing about the DDAP training and management system is that it allows us to not only just register participants for the training, but it also gives us the opportunity to get those things like the CEUs through their process. So kind of two birds with one stone through their training management system. So again, I expect that to be happening very soon. And I believe they're starting to try to schedule things now for the training, very close to that, and very excited about that to see how it goes and how it works out. Because I know it's going to be a huge success with all the work that the Brain Injury Association of Pennsylvania has put into it. I expect it to be a huge success. So much to the point where we're still planning on continuing in the future. We do have a new grant we're writing once this one is completed, to just continue what they've started, both virtually and hopefully live in person. That'll be in the next year or 2 years, perhaps. Again, that right there is in the very early stages. It's on the review process, but it will be based on the current training. So the Bureau of Family Health will continue to provide specifically acquired brain injury and opioid training programs to deliver that curriculum that focuses on the correlation of brain injury and opioid use. We will partner with an outside entity to deliver training to professionals who serve adolescents and are within the brain injury and drug and alcohol field on a statewide level. And the ABI, or Brain Injury and Opioid Training Program, will ensure the appropriate health and health-related services, screenings, and information are available to the maternal child health population. Through the training program, the outcome will be to improve the mental, behavioral health, and developmental outcomes to adolescents with brain injury and opioid use. That's what I have for our program at this point. And I wish if it wasn't for the coronavirus, we would have a lot more and a lot more to talk about and a lot more to offer. I can't wait for us to be at that point to offer more to the rest of the country. Thank you.
Thank you, Brad. So I will be diving into what's going on in Massachusetts. So some of the things that we have going on is like Maine and New Hampshire, we've been dealing with the opioid epidemic, and we've had also a governor's opioid task force that was put together many years ago, I want to say 2014. And by the time that the president declared the opioid epidemic, an epidemic in 2017, we had already done a lot of work in our state to address the issue. However, in doing that, we did not address brain injury, right? So what the MRC decided to do, we are the lead state head injury for brain injury. We provide comprehensive services for individuals with disabilities that will maximize their quality of life and economic self-sufficiency in the community. And so we started noticing in our agency that we started having a lot of consumers that had co-occurring conditions, so co-occurring substance use disorders. And as we saw that, having had some lessons learned from the previous grant, which focused on older adults, we felt like it was time to address this head on, not only for our agency to prepare our staff for the rise in seeing more consumers with substance use disorders and other co-occurring conditions, but also to help just overall the state work with individuals that have brain injuries and substance use disorders. So we put together this grant. And if you could go to the next slide, Maria. Next slide. Our focus is like a two-way focus. So we are focusing on the community providers that are in the brain injury world, and then we're also focusing on the substance use treatment providers and finding ways to link them together so they better work to serve our population. In addition, MRC has focused a lot of energy in just developing the competencies of our staff in-house. As we're seeing more and more consumers come in the door, we want to be better at serving them and their needs and meeting them where they're at. Next slide. So our project is called the Bridges Between Grant. We are a mentored funded grant through the ACL. And so we have a couple of activities that we've put together in partnerships with key folks like the Brain Injury Association of Massachusetts. They are the lead advocacy agency for brain injury in our state. We have a very strong partnership. The Department of Public Health has helped us in many ways with the registry component, and also the Bureau of Substance and Addiction Services. We're working very closely with them because they're the ones leading a lot of the opioid response efforts for the state. So it was very important for us to partner up with them and basically follow their lead in the community, who they're reaching out to, leveraging some of the funds to do a lot of the training and education that have been put together for this project. We've partnered up with the Executive Office of Elder Affairs. This is a carryover from a previous grant. Substance use it was an important topic for Elder Affairs, and we wanted to make sure that we were equipped to continue to support the ADRCs in the community. And so they're part of our project. Mass Health, they fund a lot of, they are our Medicaid, and so they fund a lot of our waivers. MRC has 4 waivers that we manage. And so with more upcoming waivers around substance use, we felt like it was just very important to have them in the table as well, so that we can get help use them to get in the door, in other doors that we normally wouldn't be able to get into. And then lastly, the BAMSI New Start Brain Injury Community Center out in Worcester, have partnering up with them, as they are the ones running a brain injury program out in Western Massachusetts that serves all individuals with all types of brain injuries, not just traumatic brain injuries. And out of that program, we're piloting a substance use intensive case management pilot that before it was limited, excuse my house phone, it was limited to the Worcester County area, but now because of COVID, we're able to provide intensive case management virtually across the state. And so with this grant, we've been able to provide Train the Trainer program, which was an 8-day intensive Train the Trainer program, which we brought on 22 speakers to help a staff of about 60 to get trained on substance use disorders, brain injury, and mental health, and how it all co-occurs with chronic pain as well. We had Dr. Frank Sparadio leading that effort, and then our partners supplemented some of the content for that training last fall, with like what's going on with the opioid response, what's going on with harm reduction, where are the resources. Massachusetts is growing a lot of its substance use programs, so it was really important to keep people up to date as to what new medical assisted treatment is happening, where to access resources, efforts that are happening. And so we've decided to take that 8-day intensive, 56 hours worth of content, and shrink it down to about 10 hours worth of content so that we could deliver it virtually. So that's what our goal is for this spring. We're developing 5 modules where in 2-hour chunks, where we're breaking out just the nuts and bolts of, you know, awareness between that intersection between brain injury, substance use, chronic pain. We're looking at screening. How do you screen for brain injuries using the modified Ohio lifetime brain injury exposure screening tool, looking at the HELPS tool, and then how do you also look at the SBIRT tool, so that we're also screening for substance use risk, right? Because our brain injury folks, they know brain injury, but then we want to train them up to be able to also assess for substance use risk. And we've developed 1-hour presentations. We're developing a lot of educational materials. We are also providing technical assistance to 2 work groups for ACL. One of them is the Opioids and Mental Health Concerns work group, where we're always exchanging resources and what we have going on in our state. I don't do all of that work. I have also subject matter experts in-house that can help us provide some of that technical assistance. In addition, we have created at MRC a substance use task force. So that's a group of staff, about 12 of us, representative of various areas of the agency, and kind of looking at our practices, our procedures, our protocols, and how we can either create new practices and policies, or how can we revise them so that they better fit where we are now with the opioid epidemic, with substance use disorders, how we could better serve our consumers. So that's what we've been up to. If you could turn to the next slide, Maria. And I want to apologize up front for my house phone going off. One of the things that we did is collaborate with the Bureau of Substance Addiction Services Department, the Massachusetts Screening, Brief Intervention and Referral to Treatment Training and Technical Assistance Program out of Boston Medical Center, and the Massachusetts Organization for Addiction and Recovery on creating what we're calling our 10 substance use principles. We needed something to anchor our staff in this work. How do we best work with consumers that have substance use disorders? How can we be better at being person-centered, being, using harm reduction? So a lot of our work is going to be anchored on this, on using anti-stigmatizing language, on using harm reduction. So we consulted with these agencies in addition to having our substance use task force develop these principles together with a lot of feedback from our 500 staff from the various programs. If you could go to the next slide, Maria. And so we spent like about a year and a half, just editing down what we want these principles to be, what's that vision, and our values, so that we can better support our consumers. And some of these are transferable to other disabilities, but we just felt like this was an area that was of need. So many things have changed with the substance use world, going from abstinence to now going to harm reduction. And we have vocational staff that have a specific type of duties, and then you have staff that are out in the community with consumers. So how do you bridge those two worlds right together, so that we have a set of values that anchor us? And so we worked as a task force with these agencies to kind of make sure that we had the right language. And so what I did for you all is that in the I think Maria uploaded a copy of our SUD principles so that you could look at them, because that has informed our trainings. So if you go to the next slide, Maria. With our trainings, we decided to do, it was a culture shift for us. So we had decided to do a top-down approach, where we had a lot of education happen for our task force members. Then we decided to focus more recently on our managers, directors, and supervisors, right? And so we created a 4-part facilitated series with the Health Resource in Action agency that is funded by our Department of Public Health, using SAMHSA dollars for the opioid response. And we created a 4-part series. So part 1 is just getting the basics, getting everybody up to date as to what's alcohol, what's marijuana, what's opioids, what does it mean to have an opioid overdose rescue response? What is harm reduction? What does it mean for us? How do you supervise in crisis? All these different various questions that directors, managers, and supervisors have. And so in getting them the basics, it's going to help us formulate our Narcan policy. It's going to help us think about how do we better do harm reduction as supervisors. Then we had individuals with lived experience, a panel of 7 come on board and talk to this group of 90 staff members, middle managers, talk about their experience. How did they engage in treatment? What were some of their challenges? What things worked? What things did MRC do well? So that we could all hear from each other and hear from their stories and learn from those. And then lastly, we brought them back and looked at the principles. How do we operationalize these principles? What do we need in terms of policies, practices, and procedures? How do we enforce these? What additional trainings do the managers need? What additional trainings do the field staff need? What is it going to look like for the field? So these are the conversations that we are engaged in. How do we bring in health equity and some of this diversity and inclusion work, that's already going on in the agency? These are the conversations that we're having parallel to the work that we're doing in training folks outside of the agency, which is really important, so that when we are working with folks outside of the agency, we're matching the knowledge. Our staff in-house are updated with the SUD practices, and so they're better able to engage with their providers as they're trying to help the consumers engage in services. Next slide. And so that's pretty much what we have going on. I do want to share, and Steve, you in our earlier conversation today, I want to share that one of the things that Massachusetts wants to do is bring back our regional collaboration that we had with the states that are in the New England area. And that's something to look forward to if you're one of those states. In the coming year, we want to start that up. We used to have that many years ago. And again, this is another opportunity for us to continue to stay in touch with what we have going on in our states, continue to share our materials, support each other. That's definitely something that we are really looking forward to. So I'm just going to open it up for questions from everybody. and we are going until, I believe, 1:15. So if you have questions, use the questions pane in the panel, and Maria will read it out to us so that we can answer. If Steve and Brad, if you want to turn on your cameras.
Gabby, there is one question in here thus far. Is there a bibliography of research on brain injury and opioid addiction?
Yeah, so several of us in the opioid and mental health concerns group, we've all kind of gathered our own list of, bibliographies that we're happy. I'm sure I could, if you send us your email, I'm happy to gather that up and send it over and share it with you. One of the tasks that the opioid and mental health concerns work group is doing is putting together some competencies for those doing this work, brain injury and behavioral health, and what things these providers should have when working with individuals with brain injuries. And we've put together a pretty extensive literature review. So we'll have to figure out how to share it with you. But if you're interested in that, just shoot an email to Maria, and we'll be happy to share with you that bibliography.
Great. Another question. Have you looked at brain injury and its associated pain with a propensity to slip into opioid use disorder?
Yes. Yes.
Oh, Gabby, you're frozen.
I can.
If you can take that, Steve, it'd be great.
I'll try. I know traditionally that's really been where a lot of the focus has been in terms of brain injury co-occurring with substance use disorder. It was folks already living with brain injury who had, again, a much greater propensity for continuing to use substances, whether opioids or others. The whole issue of what happens when an overdose or substance use actually causes the brain injury is relatively new. And again, that's really been, I think, more the opioid and overdose crisis that's really caused that. But again, from what I recall, going back at least the last 10 or 15 years, a lot of the focus has been on people who already have brain injuries and their increased propensity for.
I would have to agree with Steve there, because that's really what our training is focused on.
Oh, excellent.
Yeah.
Another question. Do brain injury patients receiving MAT need special accommodations to remain compliant? And I'm not sure what MAT is.
I think that's medication-assisted treatment, but I'm not a clinician. I don't know. Are you a clinician, Brad? Are you? But I guess we could. I think the short answer is there is a need for accommodations, because oftentimes if there's any hypoxic or anoxic brain injury, it's affecting the frontal lobe, and of course you need an intact frontal lobe to be successful in treatment. And so the extent that there can be accommodations to assist, whether it's memory or concentration or follow through or whatever those issues might be, I think it is critical to be, if you're going to be successful in treatment, you're going to need those accommodations. And others other than me or Brad or even Gabby have done, I think, certainly Dr. Corrigan would be a great resource in the work that they've done at Ohio, at the model systems in Ohio State. So.
Agree, for sure. Another question, is there a plan to disseminate the information on working with individuals with co-occurring substance use disorders and mental health disorders and brain injury to community agencies as well?
Well, I know in Maine, that's a huge focus of the ACL grant, is to reach out to those substance use disorder agencies, which also usually mental health and substance use disorder, the community agencies are serving both populations. And there's obviously a lot of overlap. But I know in the Maine ACL grant, that's a big focus, is to provide training resources, to provide, again, materials, information, as well as through resource facilitation, some level of linkage back to the brain injury community for services and supports that some within the existing lead agency, the Office of Aging and Disability Services or other agencies. So anyway, Brad, I don't know if you have any thoughts on that also. So.
Yeah, that's something that we expect to be part of our new grant. That staying in touch with communities, families, not just with the professionals, but spread it out there. Absolutely.
Great. I am looking to see if we have other questions. Gabby's having some technical difficulties.
I'm back.
Oh, great. Okay.
Today is just a bad tech day. I apologize to everybody for that. Did you have a question on screening? Did you say?
No, but we did get a question that Steve and Brad were addressing about, a plan for disseminating information, to community agencies. So I don't know if you wanted to add anything to that.
Yes, so plan for disseminating information. So right now we've developed our marketing plan, which we plan to launch in January. Once we have all of our, we're going to do a digital campaign in Massachusetts. Once we have all of our products finalized, we'll definitely upload them onto our agency website. But I believe also we're able to share them with NASHA. We could share them with ACL, in our portal. So there'll be several places where we'll be able to happily disseminate. Just you could find me at MRC or through NASHA's website, and I'm happy to share once they become final. But the goal is for January for us.
I would just add to what Gabby was saying. One thing I forgot to mention is I think most states, including Maine, have collaboratives that focus on training and resources for the substance use disorder community. In Maine, it's called the Maine Behavioral Health Training Collaborative, and it's a great resource for us within the brain injury community to link up with the substance use disorder community. They have, I think, 4,000 individuals working in the field. They have all the connections with the agencies, so it's a great partner. And again, I think most states have those collaboratives. So in terms of helping to disseminate information and education. So
yeah, for us, we will have so our Department of Public Health. So we have our behavioral health is kind of like mental health. It's on its own. Department of Public Health oversees the substance use world, and so they have regional meetings. So I know we're gonna be tapping back into those and disseminating through that network, as well as using other professional groups to get the word out as well.
Great. There is another question for you. Any suggestions on getting insurance approval for neurocognitive neurobehavioral treatment?
I think there's only a handful of states that, is it Texas, I think, was able to pass a law to require insurance plans to cover cognitive rehabilitation. I might be wrong on the state, but I know at least one state has done that. But I know it's a heavy lift because oftentimes we're battling the insurance industry. I know a bunch of states, I think, was it Gabby, I think Nicole in Massachusetts at the BIA there,
Yep.
They've worked really hard to try to get that passed by the legislature to require it in health insurance plans, but it's a huge battle because you're battling the health insurance industry and they don't want to add new services.
Yes,
Debbie,
our state has been battling that for a while now.
One of the attendees added a comment about that. Apparently Iowa has gotten approval with that as well. Thank you, Debbie.
Oh, great. Great.
Nice. Very nice.
That's a big lift.
Yes. And I feel like ours it still comes up, as we have our, advisory board. We have a legislative brain injury commission, and I feel like that's one of those topics that keeps getting pushed forward. It's in our radar. We haven't lost sight of it, but as Steve mentioned, it is a big lift.
Yeah, it's where the Brain Injury Association can really be a help. We have almost 3,000 families, caregivers, survivors on the database in Maine, and an equal number in New Hampshire, and that you can really turn out a lot of people to legislative hearings and really contacting their legislators. So again, it's an example of a partnership between the lead agency in the state and the BIAs to really, again, try to make legislative change such as that.
I had a question for all of you. States have, some states that have been working in this area have been looking at trying to gain access in order to do some screening with behavioral health and substance use. Any initiatives in your areas about that you didn't have a chance to touch on during your presentation that you might want to address?
Yeah, one of the things that we're doing in our state is just really fleshing out when doing our trainings the need for screening, you know, and right now, you know, folks can't bill for screening for brain injury, but like to tack it onto something that they're already doing and asking the questions and making the accommodations. And so we've for a while been at, promoting the HELPS tool, but we're moving away from that one and really moving forward with Dr. Corrigan's screening tool, the modified OSU tool, to equip them with another option so that they could look at lifetime screening to really make that strong connection between substance use. There's a lot of focus too on domestic violence, and so that one just kind of gave us a lot more versatility. So getting in front of folks and just showing them how to use that screening tool, just so it could also trigger some of those linkages between us at MRC and the Brain Injury Association to get folks connected to brain injury services has been really key in our part of what we've mostly been doing.
One of the 4 courses in our training, a lot of that is specific to topics, including screening tools for clinicians and things of that nature.
I know in New Hampshire, the task force is considering ways to adapt the SBIRT to be used for, again, screening and identifying folks early on who have suffered an overdose and potential with a brain injury. But it's very early on. I don't know, maybe I'd be interested to learn if any other state has done that. That'd be very, very helpful.
I think Alabama has dabbled into that. We've dabbled in more of the questions, just like modifying them and providing like a tool to help the interviewer and kind of use a tool to as cueing for the consumer to walk away with. They have a plan, there's a reinforcement of their goals and stuff like that. But I feel like Maria, you could speak to what Alabama's been doing with the SBIRT.
Alabama has been working on that, Steve. I'm glad you mentioned it. I think they're going to have 3 questions added, which is pretty exciting. I think. I don't know specifically which questions Alabama has landed on, but I think they're pulling a few questions that have been modified from the OSU TBI ID, if I'm not mistaken, but more to come on that. Another question for all of you. Aside from the ACL TBI grants, what are some other potential funding sources that might be available to help with these efforts? For example, could people use the SOAR grants from SAMHSA to fund some of these activities?
Yes, that's what we did. So that internal work that we have going on with that 4-part series, that was partly funded with SOAR money because it's the first 2 sessions. They're doing that is a standard training that's being offered across the state. A lot of our sister agencies have been taking it. And so that's how we were able to then use ACL money to do the back end, the consumer panel and the facilitated discussion with the programs. We funded that part through the with ACL dollars. But at least with the two, we had an established content. It's the same, you know, everybody in our state is getting the same messaging. They're very thorough. And we're going to continue to work with that agency because they're funded with SOAR dollars to continue the work in-house in developing that Narcan policy, maybe doing Narcan training, and things like that. So there's a lot of follow-up happening, and it's coming from SOAR dollars that are funding that program.
The training program we're developing or almost implementing is entirely outside of ACL. We do use those Title V block grant funding, the Maternal Child Health Services block grant.
Outstanding. And Gabby, for people that don't know what SOAR is, would you tell them?
No. I do not know it off the top of my head, but it's like what Sam's opioid. I can't think of it right now. So I'm sorry, guys.
In New Hampshire, we've been able to, initially when we met with the Commissioner of Health and Human Services to talk about the issue, to put together the stakeholder team, they were actually able to repurpose some money follows the person money. So of course that program had ended. I think it's maybe starting up federally again. So they had about $100,000 of that money, which they were able to use. But at the same time, I know both New Hampshire and Maine have received significant federal opioid response dollars. I think New Hampshire received about $25 million. Almost all of it has gone for treatment. And we had reached out to, again, follow up with the commissioner on that and said, how can we access those dollars to do some of the work that we've been talking about in our plan that the stakeholders put together, whether it's training or outreach or even resource facilitation. And the message we're getting is we have to change the federal legislation or when the appropriation comes through next time, make sure there's language at the federal level about brain injury being a crisis within the crisis, the opioid crisis, because that's what the folks, there's a maternal piece in the opioid crisis with children who are born to moms who have either overdosed or who are struggling with this issue. And so at the federal level, they were able to include the maternal population as a special population within the federal opioid response funds. So I think, again, a challenge maybe for NASHA or for BIA nationally is how do we get the federal language if there's going to be a new round of federal funding going to the states for opioid response, how can we include brain injury as a population within this crisis, a special population like the maternal population? So I guess that's a challenge for all of us, but I think it's an opportunity. This is a ton of money that's coming from the federal level back to the states that we as agencies and stakeholders have not been able to access.
Yeah, and I know for us, like, again, it was key for us to really partner up with our Department of Public Health because they're the ones getting the SAMHSA dollars, right? And there's so much work to expand all of our existing programs, and our approach is looking at substance use as a spectrum, and so really following their lead. Where are they? Where are they growing programs? Who are the new players? And really reaching out to those and saying, hey, do you want training? Do you want to learn more about brain injury? Has been really key to stay in those conversations with the Department of Public Health, staying in the conversation with Mass Health, because they're also paying for some of these expanded services so that we can really get in there. Because otherwise it would have been harder if we didn't have them as a partner to try to get them to take, to do the training.
Outstanding. So I see a lot of you are putting information in the question pane about SAMHSA's state opioid response grant. So sorry we cannot pull that out for you. And Shauna had a comment to make, which is great. In Arizona, they're using SAMHSA MAT, an acronym I don't know, PDOA grant funding to staff opioid use disorder liaisons in jails who screen inmates that are interested in medication-assisted treatment for brain injury. Great point.
Great.
Yes, and we've been able to, with medicated assisted treatment, our out-of-office treatment programs, we have a person who's took the train the trainer program. So now we have content that we know is getting out there to these out of office providers. They'll be hearing a lot about brain injuries, overdoses, make that connection, make that connection back to MRC, make that connection back to the Brain Injury Association so that the person is getting, covered for everything that they need. So that's been really important in our state to medicated assisted treatment is widely disseminated. Narcan we have one of those, wide distribution Narcan, figuring out where they are, who are those programs, and again, getting staff there trained so that they can continue the messaging has been key.
Excellent. Another comment from Margot, who's in New York State. The New York State Office of Addictions used SOAR money in 2019 and 2020 to fund regional and virtual trainings developed by the BIA, their Brain Injury Association, on opioid use and brain injury. The training was for addiction providers. She's hoping that's going to continue in 21. Great.
Hey,
Gabby, did you want to talk or address at all across states anything related to strategies that you guys have used in kind of initiating some relationships with your behavioral health providers?
Maria, say that again?
Did you want to come back to something we had discussed earlier about any barriers related to formulating some partnerships with behavioral health and addiction programs initially?
Yeah, so even if, and within our opioids and mental health concerns work group, there's a different combination. Not everybody is, because of where the behavioral health, what mental health and the substance use, it varies from state to state within our group. For example, like I said, Massachusetts, they're separated. In other agencies, they're together. There are some partners that are just beginning those relationships and just trying to get in the door and say, hey, this is of concern. You should pay attention to this. Let's work together. And then there's some of us that are a little further along. We're actually out there training. Just so we're all in different stages. I think the big thing is just identifying if you have the ability to just get information, data collected in your state with with brain injury. Are you collecting data that could give you a sense of how many folks are served within these programs that have co-occurring? Bring them some awareness about the intersection, and then that's one way to kind of get them in the door. Figure out what things you guys have in common that you could work towards, because at the end of the day, you want a better, when you have someone that has like the trifecta, if you just ignore one part, you're really doing them a disservice. So you got to really look at the whole person. And one example I have is like a client that has a brain injury and you're trying to get them in treatment. They have a hard time engaging in treatment. If you don't take into account why they're having a hard time in treatment because of their brain injury, then the person may not get the most out of that access to that treatment. And so it's just really important to just kind of get the overall picture and figure out who along the way plays a part in making those slight accommodations that will make a difference, for the person down the line.
Great. One other question from April. Does anyone use the Dannon Project or Stepping Up initiative in order to screen? Are y'all familiar with either one of those?
I'm not.
I just was looking to find out a little more about the Dannon Project. I'm not sure if it is in other states or not. It's a nonprofit that helps unemployed, at-risk youth and non-violent individuals re-enter the community. You probably have something similar to that.
Not familiar with that.
Neither am I.
No, doesn't ring a bell. Okay.
Sorry.
It's within mental health, apparently.
Oh, yeah.
Yeah.
I know.
Right now, go ahead, Steve.
Oh, sorry. Go ahead, Gabby.
No, I was just gonna say, like, right now our project is been like, we have our sights set on substance use treatment programs and treatment providers. Again, because they are separated. If we do another round of ACL round, we will go after more actively seek out the Department of Mental Health. We do work with the Department of Mental Health in other capacities, but like kind of we figured this time around we're just going to focus on the substance use world. So there are some room for continuing to build on what we've done. And again, with COVID just slowing us down a lot, I think that the next round is going to be that opportunity for us to kind of, not knowing that we're going to be in a more virtual environment, to kind of build more of those relationships and bring in those providers.
Yeah, I was just going to add, Gabby, there's a real need for a paradigm shift, really, in terms of behavioral health, because again, behavioral health, if you talk to folks in the field and look at the reports and studies, everything talks about, co-occurring disorders. Well, the co-occurring disorder is developmental service and mental health or substance use. Brain injury is just not, we're not really at first base yet, I guess, even but there's been a lot of work, and again, in developmental services. And so, so the model is there. We just have to, but it's going to require a shift, and we have to add a new population. So.
Yeah, and I want to add, like, as we're in our state, like, there is a strong relationship between the substance use world and the mental health. Also bringing in other populations that could tie that in for us. Hey, you're interested in veterans and you're looking at mental health. We'll look at brain injuries, older adults. Okay, you're looking at mental health. Are you looking at substance use? If you're looking at substance use, are we also looking at brain injury? So just like use either the populations, because sometimes agencies are broken out by, specific populations. Use that as your doorway. Like, hey, we have something in common. This population that you're serving also is at risk for brain injuries, and just kind of gonna always string all those pearls along the way, so that folks, you get their attention.
Mm-hmm. Thank you. That is all the questions that got submitted. Good questions.
Great questions. We're gonna continue this. We're gonna keep bringing you more information. I know there's a lot of research and things are coming up. So keep a lookout for things that NASHA has in store for you all in terms of future programs. I want to thank Steve and Brad for coming on and doing this panel with me today. We really appreciate it. And if you have additional questions, we'll make sure to email them to Steve and Brad.
Mm-hmm. Right.
Thank you.
Thank you.
Great. So if you enjoyed today's event, stay tuned for other webinars coming up for 2021. Other training events, as well as other Archive 2020 webinars, products, podcasts, and Leading Practice Academy series are all on our website. Some of our training materials are also on our YouTube channel, so please subscribe. We also offer customized training as well, like the What If There's a TBI training tool that links brain injury to substance use and behavioral health. Thank you for viewing this webinar. Please contact us to receive notice of future events and other resources, and visit us on Facebook. Don't forget to look for your evaluations after this webinar ends, and have a great day. Thank you.